All right, so the recap on our UAs as well. So SpecGrav, that's measuring our ability of our kidneys to concentrate. So if our kidneys can't concentrate, what kind of renal failure do I have? Renal failure where the kidneys are dying, which is which one? Intrarenal failure, right? And the most common intrarenal failure is acute tubular necrosis, right? That's the most common one. But it could be glomerulonephritis, it could be pyelonephritis, it could be something weird. It could be lupus, it could be nephritic syndrome. There's all kinds of stuff it could be, but it's basically, the reason why my SpecGrav is what? Low or high if my kidneys are dead?
Low.
I got two answers. I got high and low. Which one is it? So SpecGrav, if my kidneys are not working, they have intrarenal failure, they are unable to concentrate urine, what is my urine going to be? Concentrated or not? Not going to be. It's not going to be not concentrated. It's going to be very, very dilute, right? Because my kidneys are what make it concentrated. That's the whole purpose of the kidneys. Okay, so you'll see a specific gravity that is low. Sorry, over here. It's low here, but it's all going to be a low specific gravity when you have ATN. Okay, and we talked about UTIs and pyelo, right? We get urine WBCs. Just those alone doesn't tell you have a UTI. You have to have what? You have to have one of these two guys in tow to tell you that you're on your UA, and it's done on every UA. Every stick you buy from Amazon will have it. And every time they go to the ER, there's a little welcome basket there. It has 2 liters of normal saline. It also has a UA that they're always going to do. Sometimes there'll be a 12 liter in there as well. That's like the welcome package, right? Sometimes they get an X-ray if they're short of breath. They'll get a CT head if they have a headache, right? So it's all, and they got a belly pain. They got CT abdomen. So that's like the welcome package for the ER because they don't want to get sued also. So they try to do all the things. Okay, but what tells you have a UTI 100% or 98% is you have a Leukocyte or a nitrite positivity, right? Along with a white blood cell count that's elevated. Just that white blood cell count alone doesn't tell you have a UTI, because as we mentioned, sterile pyuria happens very, very commonly in the elderly. Okay, especially those that have Foley catheters too. All right, and then proteinuria. Usually we're talking about chronic kidney disease, but glomerulonephritis is known to be wasting proteins left and right. And if proteins are osmotically active, proteins pull water, right? So as you mentioned, albumin pulls water, right? BUN pulls water, sodium pulls water, calcium pulls water too, right? So water loves these things, right? It's pulling all these things. So if we are wasting protein in the urine, water is following, right? And it's actually making our urine more what?
Dilute.
Yeah, it's making dilute, but it's really going to make you really concentrate over time because you're not able to, all the water has followed, and eventually it's going to be a really high concentrated urine. All right, and then the blood. So we talked about blood briefly, right? You can measure that on a UA. You can measure that with the heme, right? So there's heme on here that can be measured. There's blood heme positivity, but if we do like a cell count afterwards, we can tell if they have rhabdo or they have like glomerulonephritis, which also has blood, right? And some crystals, some nephrolithiases also have bloody hematuria as well. So if there's just hemoglobin, if there's myoglobin rhabdo, the heme is positive, the RBC is negative, that's a sign of rhabdo. But if there's heme positive and RBC is positive, right, that's a sign of maybe like nephritic syndrome, has the bleeds, RBC is positive, right? Someone with like crystals that are forming, right? So like from Bactrim use, for instance. And then lastly, we have urobilinogen. So urobilinogen is like it sounds, it has bili in it, right? So when you make bilirubin, which is made where? Made in the liver, right? It's made in the bloodstream as well. There's unconjugated. When your RBCs break down, you have unconjugated bilirubin. It goes to the liver to get conjugated, and then you excrete it down the GI tract, right? It makes its way down the GI tract, right? So we have all this process up here in the liver is going to make conjugated bilirubin, and it's going to go down the GI tract, and then the bacteria in the GI tract, that's great. I like that. And they're going to convert that bilirubin into urobilinogen. And then your GI tract can absorb it, and the liver's like, why are you giving this back to me? What the heck, right? So it's going to just throw it all the way back down to the kidneys, which gets rid of waste products, right? So you're going to get urobilinogen in the urine when you are excreting bile into the GI tract, right? So you could see normally you do have a little bit of bilirubin being produced, right? Because your RBCs are dying every second. So that's there, that makes sense. And if I have biliary obstruction, that means I'm not able to get any bile into my GI tract, right? So here's a GI tract right here. Nothing's getting through. Nothing's getting through at all because the biliary tree is so swollen, or I have choledochulithiasis. There's something in the way. Well, the bacteria are what convert bile to urobilinogen, so the urobilinogen will be negative. If someone has a biliary process, a cholestatic pattern is what that's called, right? Biliary obstruction is called cholestasis, cholestatic pattern. Okay, obviously you're going to see like a T-bili, alk-phos, GGT positivity, but another thing you can look at is urobilinogen. It's right on the UA, right? Comes right from the ER. And then the last thing is like hepatic disease. So if the liver is inflamed, the liver is not working, it still is able to conjugate and still able to deposit a little bit of bili into that GI tract. So you're still going to get urobilinogen positivity. Okay. What else? So those are the different tests we've been talking about, right? So we got specific gravity, pH. We're not going to spend too much time on, but pH can change. We look at like renal tubular acidosis, which we'll touch on briefly when we talk about acidoses in the next section. But nitrites, Leukocyte, WBCs, that's all for what? What's that all looking at? In yellow, in purulent yellow, it's looking at UTIs, right? Blood, like glomerulonephritis, it can be looking at Rabdo, if you have heme positivity but no RBCs. Okay, so it's there's heme positive, but what? Heme positive but negative RBCs. Right, and then proteins, like glomerulonephritis might have proteins, ketones. So when we talk about DKA, ketones are important in DKA. Also, you produce ketones just when you break down lipids. And when would you break down lipids? Maybe when you're starving, when you're malnourished, when you're ETOH, you don't drink, you don't eat stuff. So there's ETOH ketoacidosis, there's starvation ketoacidosis, and there's the popular one, diabetic ketoacidosis. You can measure the ketones on the strip here, right? You can measure glucose and your ketones as well. Okay, so you can see if someone has, it's in DKA, and this is like what you teach diabetics, like they should have these at home, so they don't, when their ketones start getting super positive, they should come to the hospital, right? Yes.
I just have a question. So, if someone has all the other symptoms of like DKA, but they're missing the ketones, it's technically not DKA, or?
Correct. So DKA is DKA. So they have to have diabetes. They have to have glucose elevation, right? And actually, there's such thing as euglycemic DKA with the new agents, the SGLT2 inhibitors like empagliflozin and such. There's a such thing as a little asterisk, right? But yeah, they have diabetes for sure, and they could have a normal glucose, but usually it's more than 250, and they have the K. They have ketones, right? And the third thing is the A, which stands for acidosis. So they have to have those three things, and then you have DKA. If you're missing those three things, you can't say they have DKA. It's something else. There could be starvation, right? So there could be ETOH use. So there's other reasons why that can happen. And people take through these diets called what are they called? Ketogenic diets, right? And they go to Amazon as well and check their ketones, make sure they're still in ketosis. They're still breaking down the fats. Okay. Does that answer your question?
Yeah, one of the nurses said that, or I think it was me and I maybe misheard. This isn't true.
Mm-hmm. Yeah, so ketones are there when you are there, and they are acids too, so they contribute to acidosis. 2 out of 3 of them are, right? And this only measures one of those ketones, which is acetoacetic acid, acetoacetate, right? There's 2 other ones. There's acetate. What am I thinking of? There's acetone, acetoacetic acid, and there's also beta hydroxybutyric acid, or BHB. BHB is not detected on the UA, so you have to do a serum BHB. You'll see that being ordered a lot.
If the gap is closed, they will be negative for.
Yeah, the BHB will be also negative if the gap's closed, because the gap is a measurement of how much acid you have, and those acids, the ones that are there, that is causing that gap, are the ketones, the keto acids. Okay. All right. What else? So glucose, and we'll talk more about glucose when we talk about diabetes. But again, your glucose could be elevated because they have diabetes. Their kidneys are getting destroyed because of a diabetic process. Okay, so that's urinalyses. All right, so CAUTIs. So CAUTIs are a catheter-associated UTI. So we have our catheter in place, and we got to assess every day, do they need a catheter? So every 24 hours at least, we need to assess, is this catheter necessary? Because every day in the ICU especially, we would say, do they need this piece of plastic in them or not, right? So every day we evaluate if it's needed, and if they don't need it, they need to get some externalization process happening, right? Sometimes they can pee just fine on their own. If they're like awake and alert, extubated, it's like, well, you could let me know if you need to use the bathroom, right? It's like, yeah, I can do it. And you take it out. They don't let you know. But the next time you got to reorient them and such. But there are some contraindications to external catheters, right? So the new one we have is not Spirit. It's called with QV or something. But it doesn't matter. It's a capture bag, and it's going to capture the urine. And you got to make sure it's in place. So you change every 24 hours for men. And if they have excoriation, that's a contraindication. You can't just go, oh, we're going to see if it's getting better tomorrow. It's not going to get better with all the urine that's there. Maybe there might be some repositioning, some other things we can do, but excoriation is a reason not to have a external catheter. And they might just do a trial of internal catheter in the meantime. Right, but we'll give it a shot. We'll try to see if it heals up, but usually if they are extremely excoriated, it's not going to happen. And the reason why they might be more excoriated is because it's not getting captured in the bag. The bag has a hole in it, and there has to be something in the hole. So sometimes they can have a hidden penis. And it's not like if something I made up. This is an not FDA. It's a ICD-10 code, right? So it's an international classification of diseases. It's called hidden penis, right? So that's when they are more obese. They have a lot of testes, a lot of love to give. They have a lot of they have a very, very buried penis, right? So those patients are not good candidates for this. And you can see some people try to stick a Purewicks on them and try to get some urine out of it. Whatever they can, sure, if it works, as long as it's not causing excoriation, then that's okay. But if it's causing excoriation, then we need to progress to an indwelling Foley catheter, okay? And then for our female clients, right? So we got to make sure that the Purewick is in place. Otherwise, it can cause incontinence-associated dermatitis, IAD, and cause some more breakdown. It's changed more often. You can see this was 24 hours, and this guy is 8 to 12, right? So every shift, at least, we have to make sure it's in place. And as you know, if taking care of them, it's always going to move. It's going to move around a lot. So you got to make sure it's well positioned, all right, over the urethra. And there can't be menses or liquid stool. Otherwise, that's going to obstruct the pad there, so it's not going to absorb as well as it could. Okay, so a contraindication to male and female external catheters is if they have what? This guy right here, urinary retention. If they have urinary retention, automatically you pass go. You don't check. You don't collect $200. You go straight to what? Indwelling catheters, right? If there's any kind of urinary retention. How do you know if urinary retention? We've done a bladder scan to see, oh, there's no urine in my suction device, right? So on the wall, right there, which is always hard to explain to families. So what's that one? That one's urine, all right? So that's a, that if they don't have a urine output, then you have to then say, well, let's look at the bladder, see if there's any kind of obstruction, right? If there's urinary retention, then we have to then do a indwelling catheter. Okay, and CAUTIs themselves can happen with Foleys, but it's a lot more overblown than you would think. It's not super popular. It's actually quite rare for a CAUTI. You can get them. When you do get them, the cost is immense, right? But basically, they start getting altered. They get fever. We did urine studies. We saw they now have like Esterase positivity, nitrites positive, right? Then that might be a CAUTI. But there's all kinds of other things it could be, right? So they got fever in the ICU. That could be anything. They could have a hospital-acquired pneumonia. They could have anything that could have developed. So we have to do urine studies. We do make sure the bladder's not backed up, because that could be causing what problem if the bladder's backed up? Causing a backup of all the way up to a hydronephrosis, right? So you don't want to miss that. That's a bad situation. Right? Does it show white count greater than 10? That's leaning towards that they might have a UTI, but there's such thing as what? As sterile pyuria that can be especially prevalent in elderly and those with Foley catheters. So we have to do again to see, is there something growing in that urine? Is the Leukocyte or nitrites positive as well, right? So Leuk positive or nitrites positive, one or the other. Right? And then if they have those things, all those things check out, then you could say they have a catheter-associated UTI. But usually there's something else that's brewing. That's why they have a fever and altered mental status, right? And an elevated white count. But usually what they're looking, like the infection preventionists are looking at all the patients every day. They say, oh, white blood cell, it's up. And they got a Foley, oh, you got a CAUTI, you got to take that out. And it's like, okay, there's other reasons, right? They're an ARDS, or I'm doing a breathing trial. Right? There's other reasons why that can happen. The white blood cell count starts keep going up. Yeah, that could be the reason, right? Or they had an MI overnight, for instance. They don't know the whole story. So it's our job to kind of explain everything that's going on with the patient. All right. So again, the bladder ultrasound is super useful to let us know that if they have urinary retention, because that could cause discomfort and pain, right? Make sure there's no ascending pyelo possibility. And then if they do have a catheter-associated UTI, a CAUTI, then antibiotics are usually recommended. And how bacteria have virulence and take hold, just like with CLABSIs, with CAUTIs, they produce a film over the in the inside, on the outside of the catheter, and it's impenetrable by the white blood cells. White blood cells can't get through it once they put up their force field, right? So it's something they do to maintain virulence, so that they can then they have their little house in there, little communities, and they can then keep growing and growing and growing, right? So that's how these bacteria are so virulent. So what do we do every day? What do we do? We do Foley care. We come in there with CHG, right? And we're going to rub that thing up and down for 6 to 12 inches of the catheter so that it's going to annihilate the bacteria. It's also going to use friction to take off any kind of biofilms that might be forming, right? And because otherwise, white blood cells are doing what? So slip and slide, right? I never found those comfortable. It's like I'm hitting the ground at like full speed. It's like that's not really my thing. I'd rather have some comfort with that. That's just
lower your angle.
Yeah, it's a little. No, I'm not just falling over. All right, so CAUTI bundles are useful. Okay, so doing a no loops, right? So no dependent loops. So it shouldn't be a little loop like that. It should be a straight shot instead to the Foley bag. And then it should be below the bladder, because if you raise above the bladder, all that urine that's been static, where bacteria like to live, they're all going to get drained back into the bladder. And that's going to cause a risk for UTI, right? And then Foley care, as we mentioned. Okay, so there's a lot of devices nowadays that they've come out with to try to combat CAUTIs, or it says combat CAUTIs. Is they have you buy like a new wash machine nowadays, or a new fridge. It's like now laced with silver. So then you get like silver Foleys. It's like ding ding. I'm kidding. They're just laced with like a liquid silver or something. I don't know where it's at, but that's supposed to be a way to prevent bacterial colonization. And then someone got the idea to put infrared lights, because we have those lights that kill the rooms as well, right? So you put the lights in there, and it's going there. It has a little scatter light that's going to destroy those biofilms, and it's going to go light up. And then you go in there like at 2 in the morning. It's like do. What's going on? Oh, it's just my Foley catheter going off, right? So it's a light show.
It's like light inside the actual.
Yeah.
Into the bladder.
I'm not sure if it plugs in like USB-C or what. I'm not sure how it charges, but maybe it has a little battery, like a little one-time use, like those drinks. Yeah.